Today I'll be going over management of a patient with a recently placed ventriculostomy. I've listed some key objectives that I'd like you to take away from this presentation. After this presentation, you will have an understanding of what a ventriculostomy is, how it works, and indications for ventriculostomy placement. You will also have a solid understanding of nursing management essential for a patient with a recently placed ventric. Before we jump into that, it's essential to do a quick anatomical review. The brain is composed of brain tissue, blood, and blood vessels, as well as cerebrospinal fluid, bathing the brain in nutrients. When volume changes due to hemorrhage or edema, the brain absorbs this increase in pressure, and brain matter compensates to avoid damage. However, the enclosed brain cranium does not allow for much compensation within the brain tissue, nor physical swelling toward the outside, so pressure is directed inward, causing damage to the brain itself. This increase in pressure and changing pressure in the brain is known as intracranial pressure. Intracranial pressure is a measurement of force exerted within the brain's ventricles and cranial vault. It's created by cerebrospinal fluid, tissue, and blood, especially cerebrospinal fluid within the ventricles themselves. We prefer to see ICPs, or intracranial pressures, in the brain between 5 and 15 millimeters mercury. When a patient has an ICP greater than 15 millimeters mercury, we begin to see signs and symptoms of an increased ICP. These include headaches, nausea and vomiting, and any changes in LOC, or level of consciousness. It's also important to note that a patient may not present with all three of these symptoms, and we should be mindful of any small changes in level of consciousness. When a patient has an ICP greater than or equal to 20 millimeters mercury, we start to see changes in vital signs. This can be very dangerous, and intervention is necessary to prevent a medical emergency. Now that we've done a quick review of brain anatomy and what determines intracranial pressure, we can begin talking about how we measure ICP. One of the ways we do this is using a ventriculostomy, otherwise known as an external ventricular drain. Essentially, an EVD is a catheter placed into the ventricles of the brain, and the ventricles of the brain are the spaces where cerebrospinal fluid is formed. We place the ventriculostomy with a burr hole in the head. An EVD is unique compared to other devices used for monitoring ICP, which I will go into more of those later, because we can drain the excess cerebrospinal fluid while simultaneously monitoring the pressure within the brain. The neurosurgeon who places the ventriculostomy can decide whether he or she wants the draining of the cerebrospinal fluid to be intermittent or continuous, usually depending on the severity of the condition. With continuous drainage, the physician will set an upper level perimeter on the device itself, and a vacuum is created within the drainage system so that when the ICP in the patient's brain crosses this upper level threshold, it will automatically drain out the ventricles and into the drain. With intermittent monitoring, it is up to the nurse to closely monitor the patient's ICP and drain fluid whenever it crosses a parameter indicated by the physician. This is usually found in the documentation within the charting system itself. Once it is placed, it is closely monitored and managed by nursing staff, and it's always in an ICU. You'll never see a patient with a ventriculostomy on a general medical floor. So here I've listed 5 of the most common indications for placing a ventriculostomy, and hydrocephaly is the most common. Any stimulus that triggers an internal hemorrhage, edema, or formation of a mass elevates the ICP and may require an IVD. So what you'll notice with all 5 of these is that they can result in hemorrhage, edema, or formation of a mass, which elevates the ICP within the brain. I really like this figure because it offers a good picture of placement of a ventriculostomy. As you can see, a ventriculostomy is in the upper left hand of the photo over here, and it's placed in the ventricles. And as I mentioned earlier, there are a couple other devices we can use to solely monitor the ICP. 2 of the more common devices are an intraparenchymal monitor as well as a subdural monitor placed just underneath the skull. But again, a ventriculostomy is unique because we can simultaneously monitor ICP while draining cerebrospinal fluid. Conducting neuroassessments is dictated by the physician's needs. So with a patient who has a placed ventriculostomy, we'll see neuroassessments every 2 hours or every 4 hours, depending on the severity. Neuroassessments include perla, hand squeezing, testing sensations, asking the patient to pull you close with their hands and push you away, and doing the same thing with feet, pushing feet up and pushing feet away. Ventriculostomy patients are ICU monitored, so it's important to stay close to the patient and be watching the ICU monitor. And like I said before, paying close attention to the site of insertion and monitoring for infection. So monitoring the tubing for clogged or blocked tubes, which I'll get into that a little bit later. So the pressure transducer, which is located on the drain itself, must be level with the ventricles in the brain. This means that the ventricles in the brain are level with the tragus of the ear when the patient is sitting upright. So we want to reposition the drain so that it is sitting level, we want to reposition the pressure transducer so that it is level with the patient's tragus. So whenever the patient moves or readjusts, we want to make sure that we are moving with the patient and always staying level. And again, when the patient moves or readjusts, we also want to clamp the drain itself if they are on continuous draining for cerebrospinal fluid. And we need to clamp the stopcock, controlling the flow, because if it's not closed, the ICP reading on the monitor may be off. So if the person stands up too quickly and moves his or her ear moves above the level of the transducer, the ICP reading will be too high, and CSF will flow excessively and too quickly into the drain. This creates a vacuum within the brain and within the ventricles and can create a potential for ventricular collapse, which is a medical emergency. If the person's tragus and ventricles move below the level of the transducer, the ICP reading may be erroneously low, and CSF will actually flow backwards from the drain into the ventricles of the brain. This will commonly cause headaches in the patient and creates a huge potential for infection. In addition, every time the patient moves, the transducer must be re-zeroed to ensure accuracy, so making sure we're staying as accurate as possible with the drain. And as I said earlier, if the physician orders intermittent drainage, it's the nurse's responsibility to perform this task by releasing the stopcock when the ICP climbs above the set upper level parameters. Documentation is key because we must be comfortable with knowing the patient's baseline level of consciousness. Any change in level of consciousness can indicate a change in ICP, and we want to always be monitoring that. It's just another part of nursing management. Dressing changes should be performed once every 2 days or as needed. As needed can be if there's any kind of exudate coming out of the site of insertion. In addition, we also want to be monitoring the site of insertion for signs of infection, as this is a very common complication. I like this picture because it offers an insight into nursing care with ventriculostomy. So it's very hands-on, and it requires critical judgment and close coordination with the medical team. The nurse has a lot of autonomy in managing a ventriculostomy, especially with intermittent draining. And you can see the nurse is working to maintain the pressure transducer at the level of the patient's tragus. This photo shows something very common in ventriculostomies is that they'll have laser pointers so that nurses can accurately level the transducer with the patient's tragus. Most actually do not have these, so it's up to the nurse to eyeball the tragus and adjust the height of the EVD as needed. The number one complication is infection, and this is usually due to normal skin flora, so we want to be monitoring that site and performing dressing changes. And if a patient's ICP suddenly increases, it may be due to a blocked EVD tubing. So we want to always check to see if tubing is blocked and perform neuroassessments when it is elevated. This would be our first step in monitoring a patient with elevated ICP. Another complication is draining too much cerebrospinal fluid, which can lead to a collapse of the ventricles. Like I said, medical emergency. And our fluid and electrolyte imbalance occurs when we drain too much cerebrospinal fluid. We want to be monitoring that, drawing labs. And additionally, hemorrhage is a common complication. It's not the most common. Like I said, infection is the most common, but this is something we want to be looking for, any change in level of consciousness. I've left you with some key considerations. So whenever we're moving the patient, we need them to know that they need to be moved with a staff, either an NA who's been trained or a nurse who knows to clamp the drain and readjust when they are sitting down. We need to be mindful of cardinal signs of elevated ICP, so change in level of consciousness, and we need to review patient's chart to be comfortable with a baseline level of consciousness. And here are my references.